A risk factor is actually any attribute or characteristic that would place one at risk of getting a particular infection. And the term is actually used quite loosely, right? As you can see, a diagnosis can be a risk factor like hypertension. On the other hand, some sort of exposure like environmental exposure is also considered a risk factor. And certain physical attributes like being underweight or overweight can also be a risk factor. But when you look into the Aspergillus literature, unfortunately the term risk factor is not quite used. And this is a very much quoted article by Raoul Hebrecht, where he actually noted that the type of patient whom we usually think of as being at risk of aspergillosis, he calls them primary host factors. And we all know what these host factors are. Recipients of allogeneic bone marrow transplant, certain types of immune deficiency disorders like chronic granulomatous disease, and recipients of solid organ transplants. And indeed, the EORTC MSG guideline also avoids the use of the term risk factor, preferring instead to use the term host factor, meaning that you have to look at the type of host when you decide whether or not this person is at risk of developing aspergillosis. And here, slightly different from Raoul Hebrecht, they define this host at risk as being someone who's been neutropenic for a certain duration, who's been on steroids, taking steroids at a certain dose for a certain duration, and who's been on some sort of T-cell immunosuppressant. So be that as it may, what I think I'm being asked to address, and what is getting more and more topical in the literature, though it's not burning quite like Candida auris, is that we are trying to look at certain conditions or associations that are not quite conventional, not quite classical, but would certainly also place the person at risk of invasive aspergillosis. In other words, are there patient populations other than our transplant recipients and our neutropenic patients who are also at risk of invasive aspergillosis? And so this is one of the early papers that sparked of interest in this atypical host problem. So this is a hospital in Belgium. They are blessed by the fact that they are able, or they have always been doing lots and lots of autopsies. So they looked at all these deaths that were autopsied and only included those that were autopsy confirmed to have invasive aspergillosis. And when they looked, they found that yes, there are of course quite a lot of patients with an underlying hematologic malignancy, but there are also lots of patients who did not have a malignancy and who died of invasive aspergillosis. And as you can see, some of these we already know, right? You have solid organ transplant, some sort of autoimmune disease with immunosuppression. But what they found was that there were a few cases who would not have qualified by the then existing EORTC criteria. And so the Europeans came together and set up this study group where they tried to systematically look for invasive aspergillosis in the ICU. And the proven category, well, you can't run away from proven. You must show the fungus invading tissue, and you must grow aspergillus from a sterile site. But in the probable category, they have chosen the term putative, which is quite good, so that when we talk about putative aspergillosis, you actually know that we're talking about the ICU host, the ICU patient. And here, the major thing is that, number one, you must have it growing from an ETT or BAL or sputum, I suppose. Right? Then for a clinical symptom, they define 7. Some of them are quite reasonable, like fever, persisting despite 3 days of broad-spectrum antibiotics, or fever that is recrudescent after a 48-hour afebrile period, and then you have all the other things that we classically associated with pulmonary aspergillosis anyway, hemoptysis and pleuritic chest pain, right? And then for imaging, which as always is crucial, they have chosen to be rather lax, just any image, CT or chest X-ray abnormality. And finally, as a clincher, they again went back to basic microbiology. That means you must have good growth, 2+ or 3+ in BAL, and you must see it you must see the hyphae on cytology or under direct exam, and you must not grow bacteria, of course. So with this, they went to look to get 8 countries to participate, and you must be surprised to find that they had almost 300 cases of invasive aspergillosis that they were able to diagnose in this way in these ICUs. But if you think about it, that's 30 ICUs, and this is a 10 or 11-year period. So 300 cases, 30 ICUs means 10 cases per ICU. And over 10 years, it means one ICU only contributed 1 case a year. So I think that one lesson here is that yes, we are truly dealing with a rather unusual condition, but also that if you want to do a good study, if you want to create knowledge, you must actually have tenacity, going to 30 ICUs over 10 years. And the most important finding is that a large percentage of these patients, more than 3/4, would not have been included at all if you had just stuck to the EORTC MSG criteria. So sure, there are patients who have had a bone marrow transplant. There are patients who are neutropenic, who have had a solid organ transplant and who are on a variety of immunosuppressants. But you will also get patients with COPD, chronic heart failure, and ethanol abuse developing invasive aspergillosis. So let's try to understand this a bit better. Now this curve just shows you that although they may have rather arbitrarily created their definitions, actually it seems to be that their way of classification is probably right, because those with proven Aspergillus, of course, did very poorly. Survival was very poor, and the putative arm did intermediate between those who are merely colonized and those with proven disease. So what actually was happening? So this is the basic science that underlies this risk. That during sepsis, and we're talking about ICU patients, there is a huge cytokine storm, and we all know that. And this is TNF-alpha, interferon gamma, probably drive the fever and the septic shock. But at the same time, the body is always trying to restore balance and homeostasis. So you will also see some of these IL-10 type enzymes and cytokines, and you find that there is an attempt to restore balance. But unfortunately, if the illness drags on, sometimes it is these immunosuppressive cytokines, the Th2 cytokines, that persist. And that's why patients who languish in our ICUs go on to develop secondary nosocomial infections. And you can look at the basic science. Plenty of studies looking at all these individual cells and how they all become less functional, in the sense they become suppressed as sepsis drags on in the ICU. For example, NK cells, lose their cytotoxic function. Neutrophils begin to secrete more IL-10. Macrophages do not produce as much by way of pro-inflammatory cytokines. And as you know, these are really, really important against Aspergillus, because what defenses do we have? So number one, why is it that Aspergillus, despite being ubiquitous in the atmosphere, is actually causing disease only in those who are truly compromised? Because we have a functioning mucociliary tree that excludes these Aspergillus cornidia, right? And those Aspergilli that do reach the alveolar macrophages, we have functioning macrophages that are able to phagocytose. And then these macrophages will recruit polymorphs, and the polymorphs will also assist in killing. So these are the components of our T-cell immunity with a Th1 response that are actually very, very important in protection. So this is just a cartoon, and it shows that all these things are very important. So there is an immunoparalysis in septic patients in ICU, because somehow all these cellular functions move towards an immunosuppressive Th2 type response as sepsis drags on in the ICU. But the other important thing is that we mustn't just, say that these patients are developing aspergillosis in the ICU because they have become immunoparalyzed. So this is a very interesting and important paper, I think, and it's published by Didier Pitet in Geneva. So at that time in the ICU, they had this patient with COPD. Of course, he was on prednisolone, to be fair. He went on to develop respiratory failure, got intubated, and they kept growing ETT from Aspergillus from ETT aspirates as well as BAL, and then he perished. And then sometime later, in the same month, another COPD patient who also went into respiratory failure, needed ventilation, and who grew Aspergillus fumigatus from every sample. So what they did was they suspected that something was wrong because this was unusual in their ICU. The two patients had actually been admitted to the same room, and when they looked at the logbook of maintenance, they found that actually air filters in that room had been replaced in early March. And therefore, allowing for some time after washout, they perform experimental replacement of the filters. So you find that on the surface of the filter towards the room, of course, those were clean, free of Aspergillus, but the other side of the filter is actually very dirty with a heavy growth. And at the time when you change the filters, you can actually grow Aspergillus from the air in the room. So I think that whenever you do see Aspergilli growing from non-compromised patients, it's good, of course, to be able to pick it up and to treat the patient. But it's also important to wonder whether or not there has been an infection control lapse or mishap in the ICU. So now other people have gone on to study the problem of aspergillosis in the ICU patients, and this is quite an important study where they realized that of all the autopsies they performed, 6 had disseminated aspergillosis, and 5 of these 6 were COPD patients on steroids. So we can now probably look at the problem of COPD and invasive aspergillosis. And this is an early paper. It's just a case series from Spain, and there were a few patients, 3 of 24, who had not actually been on steroids. So this is yet another case series. I think this is American. The authors themselves had 5 cases, and because of that, the interest was piqued. They went to do a literature review, so there were 65 cases in all. The criteria had not been quite established, so they used the EORTC criteria. So as you know, if you use EORTC criteria and your underlying condition is not neutropenia, then it's got to be high-dose steroids or it's got to be a proven diagnosis. So using something like that is actually useful because it forces you to fit the patient into a slightly different mold. And if you still get a diagnosis, maybe you should really think that there is some truth in this association. So all were quite elderly, all had very advanced disease with a very poor FEV1. A lot had a recent exacerbation, which implies more steroids, more antibiotics. And of course, unfortunately, symptoms and signs were not consistently reported. So why is it that COPD patients might also be at risk of invasive aspergillosis? Well, like I said, the mucociliary escalator is a very important part of our defenses against aspergillus. So chronic smoking will impair ciliary function. Antibiotics, these people are frequently on antibiotics every time they are admitted, so this probably alters the microbiome. And of course, many of them are on steroids, which we know are a classical risk factor for invasive aspergillosis. So with the increasing reports, I think it was necessary to come up with a definition. So this group has come up with a definition that many people use. We also use this definition in our Asia mole study, and basically they use the proven, probable, possible terminology that the EORTC used. And here basically it is a COPD patient, severe by Gold stage 3 or 4 with recent exacerbation of dyspnea. And again, they are lax about the chest imaging, not insisting on a nodule. But again, a positive culture or and microscopy is considered important. But they accept an antibody test and in response to some of the questions that people ask, they do accept 2 consecutive serum galactomannan tests. And if you look at this paper is actually an ICU paper. So they use the ASP ICU criteria. Hence, they use the word putative. But if you look at this, you find, and you combine, you do a proper case control study, you find that IPA is a strong predictor of death, and a more important predictor of death than some of these standard things that you think of, predict a poor outcome in an ICU patient, such as the need for renal replacement therapy or vasopressor therapy. Now, if you scour the literature, you find that there are quite a few of this type of case reports. I'm intrigued by the fact that although there aren't so many, almost all of them are Asian cases of aspergillosis in diabetes mellitus. And in fact, hyperglycemia is a well-known risk factor for mucormycosis. But for invasive aspergillosis, the data are not so strong. Here is one of these febrile neutropenia studies, and hyperglycemia did turn out to be a major risk factor for a complicated infection, including IFI, but again, not very specific for Aspergillus. This is our recently published Asia-Mole study. As I was analyzing the data, I was struck by the percentage of patients who are diabetics in this study. Of course, this is not limited to aspergillosis, and because there are no criteria, no published criteria out there to enable us to properly recruit a diabetic, they were all in because somehow they fitted other criteria, right? The other interesting thing, and I'll come to it later, is that, of course, there were some people who had diabetes as the only underlying condition, but there are also people who had other conditions, perhaps more of the classical ones. And this is actually not unique to our study. This is a Thai study. This one focused only on Aspergillus, and 17% of their patients had diabetes. This is a French cohort. This is Raoul Hebrecht's unit, where 18% of their cohort also had underlying diabetes, though not as a sole condition. But what they felt was the 18% was higher than the usual rate of diabetes among patients admitted to their Him-Ong unit. So maybe there is something about diabetes. Now we go on to another condition, and this is a hepatic failure, which is being recognized as a risk factor for diabetes. And this is a very old paper, Tom Walsh in a younger iteration. This is more than many years ago, reporting 3 cases of fatal proven aspergillosis in patients with hepatic failure. But of course, all of them had been on steroids, although not for very long durations. So people have looked at this. Alcoholic hepatitis, this is a series where out of 94 cases, a lot had been treated with steroids, and quite a few fulfilled criteria for the diagnosis of invasive aspergillosis. The main thing is that, unfortunately, of course, a lot had received steroids. So this is a Chinese study, also looking at this paper. I think in China, very high rates of hepatitis B. That's why over 4 to 5 years, they managed to find 700 over patients with acute on chronic liver failure, and 39 had invasive aspergillosis, with age, hepatic encephalopathy, and steroids being independent risk factors for the development of aspergillosis. Now, why is it that liver failure patients are also at risk of invasive aspergillosis? So again, some very good basic science papers have been published. This is neutrophil CD16 expression, and CD16 expression implies that the neutrophils are able to bind to opsonized microbes. And you can see that patients who had acute liver failure were like patients who were in the septic cohort, and they had their neutrophils were not quite able to bind to microbes as compared to healthy controls. So HC refers to healthy controls. And if you look at the neutrophil phagocytic activity, the ability of these neutrophils to perform phagocytosis on the first day that they're admitted to ICU, patients with subacute liver failure actually do more poorly. So here it's very interesting. Acute liver failure patients do a bit better, but as if the failure drags on, you find that they will also, their neutrophils will somehow also lose the ability to phagocytose. So there is some basic science behind the observation that patients with hepatic failure are also at risk of developing disseminated aspergillosis. So this is a case that we saw a few years ago. This man comes in, standard patient coming into an internal medicine unit, fever, cough, rhinorrhea, pharyngitis. You think this is just a flu, why even admit such a patient? But unfortunately, a few days later, he goes into respiratory failure. He's proven to have influenza, and then he needs to go to ICU, but he does recover, right? This is pre-intubation, this is during intubation, and this is after. And actually something is happening because this infiltrate wasn't there in the upper lobe, but anyway, he does get out of ICU. He goes to the rehab unit and is preparing to go home when he is found to have a fever. And this is the CT scan. As you can see, there's actually cavitation. And because of the fever, a very alert resident actually already sends off a sputum culture. So by the time 2 or 3 days after this, when we do TTNA, this is what we get. We actually get fungal elements. And of course, this is Aspergillus, not only from the sputum sent a few days ago, but also from this sample. And this is a report that we put up. I don't know whether it was the same patient, but we put this up in our AFWG newsletter. So it is probably worthwhile for you to delve into our website off and on and get some little snippets of clinical information like that. Now, aspergillosis following influenza, again, is not a totally new condition. And this has been reported, this is 1950 in the BMJ. And actually, lower respiratory virus infections of the lower respiratory tract have been associated with aspergillosis in the classical host, like the bone marrow transplant population, right? So a CMV disease increases the hazard ratio. Respiratory infections in the lower respiratory tract, also RV, respiratory virus infections in the lower respiratory tract also increase the risk of invasive aspergillosis. And this is a very interesting paper which tested all the ICU patients in their unit during this flu season. So in this California, so they have a very well-defined flu season, and 8 were positive for influenza, and 6 of these went on to develop invasive aspergillosis. So I suppose if you were the reviewer, you would say, rubbish, you must be having an infection control problem. I suppose the authors must have argued that none of the other 40 patients who had flu in the ICU, who didn't have flu in the ICU, went on to develop IA. So I suppose that's how it got published. And this one gives you lots and lots of information based on these 8 patients. Quite a few of them were lymphopenic. Only 1 had received steroids. So again, is there a link between Aspergillus and influenza? Is there some reason? Again, if you go into the basic science, lots and lots of papers. As we know, after influenza, patients are at risk of developing pneumococcal infections, Staph aureus infections. So again, lots of basic science paper, probably disruption of mucociliary clearance, depletion of alveolar macrophages by flu, suppression of alveolar macrophage activity, a shift to a Th2 response. So a lot of these things, that's why I think some of our patients with severe influenza actually resemble patients who are truly septic in the ICU. So if you look at it, and this is what I was pondering, if you look at the clinical algorithms that have been published, this is from Blot. This is the ICU paper where they use the word putative. A culture is the entry criterion. And if you look at Bulpa's paper on COPD, a culture is also a very important component of the diagnosis. So, and therefore many people will ask, why place so much emphasis on culture, right? Dr. Chakrabarti alluded to the fact that sometimes when we get a positive culture, we can't tell between colonization and infection. So here is a very good case control study. I think this is a Chinese group. They looked at COPD versus other immunocompromised hosts, and they just look at the issue of Aspergillus cultured from the lower respiratory tract, and they force-fitted the patients into the EORTC criteria. So if you are a true, one of the standard immunocompromised hosts, and Aspergillus is grown, then 91% of such patients have pulmonary aspergillosis. This one we don't neglect, right? And this one we know will fulfill criteria for probable under EORTC. But if you look at IPA in COPD patients, and of course they have to be on steroids, otherwise they couldn't fulfill the EORTC criteria for probable. Then, growing Aspergillus, 2/3 of these patients also end up with IPA. So I would suggest that in COPD patients on steroids, isolation of Aspergillus in respiratory secretions is actually very, very worrying for IPA. This is a Spanish group. They look at non-neutropenic, non-transplant patients with positive Aspergillus cultures, and they applied the BULPA criteria. And this is the first paper. The first paper actually wasn't very good. But what they did was they followed up all the colonized. So all those who didn't fit the criteria for probable and proven were just followed up. Now, the paper is weak because, of course, this is a multi-center study and not many people were as tenacious. Some people did not keep providing data on those patients. But nevertheless, they were able to follow about 67 patients, and 17.9% developed aspergillosis, and all had COPD, advanced COPD. So again, I think if you have advanced COPD and a positive Aspergillus culture, you should follow the patient up very closely for development of invasive aspergillosis. I think Dr. Chakrabarty already touched on the topic of galactomannan. You can probably use it. This is the early Measurement paper suggesting some value. This is the second Measurement paper, very much quoted. This is from AJR CCM, in which they systematically tested for galactomannan in BAL in the ICU non-compromised patients, and they were able to show that at this cutoff, you have fairly good sensitivity and specificity. And this is yet another paper where BAL galactomannan gives a better AUC of the ROC curve than serum galactomannan. But it doesn't mean you can't do. It just means that you have to think about it, do the BAL, remember to send the BAL for galactomannan as well. I don't have time to go through this, but people are recognizing that toll-like receptor 4 polymorphisms probably predisposed to IA, and this is in a bone marrow transplant population. But what is also interesting is the concept of risk factors acting in concert, and I briefly alluded to that in the Asher-Moll study. If you are seronegative and you don't have a particular type of polymorphism, then the risk of developing invasive aspergillosis is only 1%. But if you are CMV seropositive and if you have this S4 polymorphism, then the risk increases 12 times. So Raoul Hebrecht went through and decided that, depending on your underlying host factor, there is probably a staircase of risk for invasive aspergillosis. But more than that, it is also probable, and this is not yet proven, actually it's fertile ground for a good epidemiological study, that 2 or more risk factors are probably able to act in concert to place a patient at risk of developing aspergillosis. Now you will think that there are really so many criteria to remember. There's the EORTC criteria, there's the putative criteria from the ASP-ICU group, there's the BULPA criteria for COPD. But if you use different criteria, you will get different cases. And that's not a weakness. That, to me, is a plus point. It's just that the clinician has to use his brains more when looking at all these different types of patients. So whether you are in the ICU or following people with COPD or dealing with these cirrhotic patients and their shrunken livers, always think Aspergillus. Thank you.